Get started. Okay. Welcome to JOWMA's Women's Health Committee webinar on cancer prevention and screening. I am Dr. Denise Moses, Treasurer of the JOWMA Women's Health Committee. I'm a board certified OBGYN in Queens, New York. I would like to introduce our moderator for this evening, Dr. Rachel Kirschenbaum. Rachel Kirschenbaum is currently a third-year resident in obstetrics and gynecology at Lenox Hill Hospital in New York and plans on becoming a generalist OBGYN. Though originally from a suburb of Chicago, Rachel has been in New York since first attending Stern College for undergrad and then went on to earn her medical degree from Albert Einstein College of Medicine. She is incredibly passionate about women's health and is also interested in global health, having visited Guatemala, South Africa, and Kenya on medical missions. She is very excited to be participating in her first live JOWMA event with you tonight.
Thanks so much, Dr. Moses. The Jewish Orthodox Women's Medical Association, also known as JOWMA, is a nonprofit organization whose membership includes Jewish Orthodox female physicians and trainees. Our department, the Women's Health Committee, was created with the goal of increasing access to women's health education to the Orthodox community, thereby empowering women to be better equipped as self-advocates. We believe it's important to have a baseline understanding of certain topics in order to be able to ask the right questions and therefore have an improvement in health and wellness. If you haven't done so already, please take a minute or two to fill out the pre-webinar survey. You can find a link to the survey in the chat. There will also be a post-webinar survey, which you will receive after the webinar. Please try to fill out both surveys, as this will help us conduct research on this education. Those that fill out both surveys will be entered to win the Amazon gift card. Tonight, we'll be covering cancer prevention and screening. This webinar will cover different types of cancers, how to get screened, who should get screened, who should get genetic testing, how to prevent certain cancers, and an overview of how to treat some cancers. We'd also like to remind you that this forum does not substitute for getting individualized medical advice from your doctor. There'll be a Q&A at the end of the event. Please keep questions broad. All questions should be posted in the question box. If you'd like your questions to remain anonymous, hit the Remain Anonymous button. Your presence on this webinar is completely anonymous. Your video and voice are not enabled, and attendees cannot be viewed. Your presence here is completely anonymous. I'd like to thank our generous sponsors, JScreen and Invitae, for partnering with us in promoting women's health education and helping women to explore options in terms of their genetic screening. I'd like to present our first speaker, Esty Rose from JScreen.
All right. Are we good? Can you see my screen? Yeah, okay. So thank you for having me. I'll be talking tonight about genetic testing for cancer susceptibility genes. Just a quick disclosure, I am employed by JScreen, who is sponsoring tonight's event. So tonight we will talk about what will genetic testing tell you, what should you do with this information, who should do genetic testing, and how do you get tested? I'll only be speaking pretty briefly for about 5 minutes, so I'm gonna kind of run through the basics of all of these questions, but if anybody has any personal questions or any more specific questions after, please feel free to reach out to me. I'll give my information after the end of my talk. So what will genetic testing tell you? So we have more than 100 different cancer predisposition genes. If somebody has a mutation in any of these genes, that would increase their risk for certain cancers. So probably the most common one that people know about is the BRCA1 and BRCA2 genes, also known as the BRCA genes. So I'm just going to use those genes as an example here. So here you can see that the general population, those people in the navy, have a risk of having female breast cancer, ovarian cancer, male breast cancer, prostate cancer, and pancreatic cancer. Everybody has those risks, but the risks aren't that high for the general population. However, if somebody has a BRCA1 mutation, those risks increase. So for example, think about female breast cancer. A female who does not have a BRCA mutation has about a 12% chance of getting breast cancer. If somebody is a female and does have a BRCA mutation, that risk increases to about 87%. Similarly, with ovarian cancer, the general population risk is about 1 to 2% to have ovarian cancer. But if someone has a BRCA1 mutation, that risk is up to 40%. Similarly with male breast cancer, prostate cancer, both in men, and pancreatic cancer in both males and females. So if somebody has a BRCA mutation, they're greatly at increased risk for these types of cancers. However, it's not just the BRCA genes. There are actually many other cancer susceptibility genes. We know of about more than 100. And each of these genes is associated with a different type of cancer. So I wrote some examples here on the side. It's not only breast cancer and ovarian cancer, there are other genes that are associated with all these different types of cancers. There are about 40 different cancer types that are associated with mutations in cancer genes. One other thing I wanted to mention is that most cancers are actually not hereditary. Most cases of cancer are sporadic, they happen by chance, or they're due to something environmental. When we're talking about breast and ovarian cancer specifically, only about 10% of cases of each of those cancers is actually genetic. Most cases of cancer are actually not genetic at all. So what should you do with this information if you do find out that you have a mutation in a cancer gene? So the first thing to do would be to speak to your doctor, because if you speak to your doctor, you can come up with some kind of a plan to manage these risks. So I'm going to use BRCA here as an example again. So let's say we find that a woman is a carrier of a BRCA mutation. So she will go for more, the genetic counselor will speak to her about more frequent cancer screening. So for example, maybe getting mammograms more often, or breast MRIs or breast ultrasounds. They'll also talk about the options of having risk-reducing surgeries, like for example, having a prophylactic mastectomy or removal of the ovaries. They'll also talk about targeted cancer treatments if they do find cancer at an early stage. Sometimes they can do specific treatments based on the genetic mutation that caused that kind of cancer. They'll also talk about doing certain lifestyle changes like diet or exercise or reducing alcohol intake. And if the person is of the age where they're still thinking about having children, I'll talk to them about different options they have that they can do to not make sure that they don't pass down that genetic mutation to their babies. So what I'm talking about here is to do IVF, in vitro fertilization, where they create an embryo outside of the body. And before they implant that embryo into the woman's body, they can actually do genetic testing on it to see whether or not that embryo has the mutation. If it does not have the mutation, they'll go ahead and they'll implant it into the woman's uterus, and hopefully it will lead to a successful pregnancy, a child who will not have that mutation. And if it does have the mutation, they will discard it in the lab and it will never become a baby. So my point is,
sorry, I asked you one more minute.
Okay, my point is that knowledge is power. If you find out that you have a mutation in any of the cancer genes, there's something you can do about it. The second thing to do with the information is to share it with your family members. Most cancer genes, the way that they are inherited is called dominant inheritance. If a woman or a man has a genetic mutation that causes cancer, each of their children have a 50% chance of inheriting that mutation and inheriting those risks that are associated with those genes. Who should test? Historically, we only tested people who either had a cancer diagnosis or who had a family history. Nowadays, we recommend that anybody who's interested gets tested. It's not that expensive anymore, and many insurance companies cover the testing now where they used to not test. So anybody who's interested in finding out their risk should definitely go ahead and get tested. Where to get tested, you can go to your doctor, or there are a couple of at-home options. Obviously, I put JScreen at the top, but wherever you end up going, make sure it's at a reputable place that has medical oversight. So do not use 23andMe, which is for recreational genetics. JScreen has a great option where we have the Cancer Gen panel, where we're testing for over 63 genes on a saliva sample. So you order the kit online, we send you a saliva kit to your home. After about 2 weeks, the results come in, and we will discuss your results over the phone or by Zoom. So you will always be speaking to a genetic counselor. Anyone who's over 21 years old is eligible to come through our program, whether they're male, female, any background that they have, whether they're Ashkenazi or Sephardi or a mix or not Jewish at all, anybody can come through JScreen. And the price of the test is very reasonable. It's $199 if you give us your insurance information. And if you decide not to give your insurance information, it's $349. So the JScreen test is available to anybody in all 50 states. And it's pretty easy and accessible, and everything is done under medical oversight. This is just a quick pictorial of what we do, but if anybody has any specific questions about what we do at JScreen or any specific questions about cancer genetic testing, please feel free to reach out to me.
Thanks so much, Esty. I'd like to now introduce our first speaker, Dr. Mira Hellman-Ostrov. She's a board-certified gynecologic oncologist. Dr. Hellman received her medical degree at Downstate University Medical Center with a lifelong membership to the AOA Honor Society. She completed her residency in obstetrics and gynecology at Long Island Jewish Medical Center in fellowship training in gynecologic oncology at SUNY Downstate in Brooklyn. Dr. Hellman's career has been focused on academics, and she's always taught medical students and residents. She currently works at the John Thayer's Cancer Center and Hackensack University Medical Center and is an assistant professor at the Hackensack Meridian School of Medicine. She serves on the residency review committee and is the specialty clinical instructor for minimally invasive surgery. She's a certified intuitive instructor, instructs other surgeons in robotic surgery, and functions as a surgical consultant for Ethicon Surgical. She's very active in research and is a primary investigator on several ongoing research projects. She enjoys helping with community outreach and serves on JOWMA's board of directors. Thank you, Dr. Hellman-Ostro.
Thank you for having me. It's a pleasure to be here. Let me just share my slides. I will get this right. Okay, are we good? Okay, first of all, thank you for allowing me to speak tonight. It is my pleasure to talk about cancer prevention and early detection. We have this lecture split up into 3 separate sections. I will be covering cervical cancer screening and ovarian cancer screening. My name is Mira Hellman-Ostro. I'm a gynecologic oncologist at the John Thayer Cancer Center at Hackensack University Medical Center, and I'm also Secretary of Board of Directors of JOWMA. Here are my disclosures. And just as a disclaimer, as mentioned before, this content provided is for informational purposes only. It's not intended as medical advice or as a substitute for the medical advice of your personal physician. So please consult your personal physician for specific advice. Starting with cervical cancer, I just wanted to go a little bit over what exactly is a pap smear and what it detects. So this is a little pictorial view of what actually occurs in the office when a pap smear is performed. A device known as a speculum, which can be either metal or plastic, is inserted vaginally. And once inserted vaginally, the provider has this view, a view of the cervix, and cells are brushed off of the surface of the cervix, either with a brush or a spatula. What occurs is once the specimen is obtained, it is sent to the lab and it is placed on a slide. And someone known as a cytopathologist, that's a doctor who specializes in looking at cells, analyzes the cells to determine if there are any abnormal cells over there. This is a little picture of what a cytopathologist might see under the microscope. All these different colored things are individual cells. This clump here has a bunch of cells. And as you can see, there are these dots in the center that are a little bit enlarged compared to some of the other dots in the center. And that can be an indication of abnormal cells. And a trained pathologist or trained doctor looking at this will be able to tell, are they truly abnormal? Are they not? How abnormal are they? And are they precancerous? So what is a pap smear? A pap smear is a test performed by a gynecologist or a family physician to detect either precancer cells or the presence of the HPV virus on the cervix. Both of these, both precancer cells and the HPV virus, can serve as detectors, used to detect precursors to the development of cervical cancer, and that's why we screen for them. When a pap smear is performed and it's analyzed, if it's abnormal, usually that triggers a further workup, which can include something called a colposcopy, where in the office, a gynecologist looks at the actual cervix with a microscope and does biopsies to determine whether there are truly precancerous cells there, to rule out cancer or any other abnormalities. As stated on the first bullet point, pap smears can either detect the presence of HPV or actual abnormal precancer cells. And there has been an increasing trend among various medical organizations to use just the HPV screening alone in order to determine if there's a risk of developing cervical cancer or not. So who needs a pap smear? Pap smear is really needed by every woman over a certain age, and the starting age for pap smears differs between different society recommendations. The U.S. Preventive Task Force Service recommends screening to start at the age of 21. as opposed to the American Cancer Society, who recommends that screening starts at the age of 25. One recommendation is that a pap smear is performed every 3 years, ages 21 to 29, just looking for abnormal cells, not looking for the HPV virus itself. The reason for that being is that the HPV virus is so common, almost every single test is going to come up abnormal. After the age of 30, though, there are various ways to screen. Either someone can have a screen where they just look at abnormal cells every 3 years with regular pap smears, or combine looking for the HPV virus with abnormal pap smears every 5 years, or just looking at for the HPV virus itself every 5 years. All three of those methods are considered acceptable modalities for screening for the age of 30 to 65. Alternatively, the American Cancer Society recommends to start screening only at the age of 25, not 21, and they recommend only HPV testing alone or HPV with cells, but every 5 years. So either way, screening is every 3 to 5 years with or without cells or HPV testing, and all these are accepted modalities that really have detected and eliminated a significant number of cervical cancers in the United States. So this HPV virus that causes the precancer cells on the cervix is usually transmitted through intimate relations. As many of you may be aware, this can occur in people who have intimate relations. And one may think that, you know what, maybe this doesn't apply to me as, let's say, a monogamous Orthodox person. So I just wanted to share with you 3 stories from my personal experience as a GYN oncologist. And these are not isolated stories. They're just examples that came to mind of people that I have personally treated. And I just want to note that these initials are completely fabricated. These are not the patient's true initials. So TW is a 26-year-old female, normal female, got married, first pregnancy, pap smear is not normal. During her pregnancy, she needed something called, what we discussed earlier, the colposcopy. Her cervix needed to be analyzed under the microscope and needed to have biopsies performed. She, thank God, proceeded to a normal pregnancy, had a normal, healthy baby, but then was subject to a significant amount of screening and testing and biopsies for several years afterwards. RH is another young woman, 43-year-old lady who was married for 20 years, who presents for the first time with an abnormal pap smear. She had biopsies that were performed due to the abnormal pap smear and was noted to have precancer cells, which resulted in her needing a minor procedure known as a cone biopsy to eliminate those cells. And subsequently, she needed to be screened and tested and had biopsies performed intermittently for the following 20 years, and is still currently being screened. And this last example, which is maybe on the more extreme end, but it is a true story, 28-year-old woman who was diagnosed with advanced cervical cancer. She needed radiation treatments. She was unfortunately diagnosed before she even got married. She had her eggs frozen and thankfully had a successful pregnancy through a surrogate. So, we do have great screening mechanisms to prevent cervical cancer. But truly, the best form of early detection is prevention. So how do we prevent cervical cancer? We currently have something wonderful available called the HPV vaccine. I know we've all heard about vaccines recently. Last year was measles outbreak. This year we have the COVID vaccine. So it's a common word that's been going around, but we do have a great vaccine for this HPV virus. It prevents infection by 9 different HPV strains. 7 of these strains are actually precancerous strains. And this really accounts for about 80 to 90% of cervical cancers. And 2 of the strains are not precancerous strains, but they do cause significant unsightly genital warts that can be prevented with this vaccine. I'm not going to go into a lot of details about the vaccine because that's its own talk, but I did want to bring your attention to it. So this is a brief diagram of what the vaccine actually does. You can see here is a recommendation where the vaccine is to be administered. This would be the graph of someone who did not get the vaccine with a significant number of precancer cells and then cervical cancer. And this is the graph in someone who did receive the vaccine, obviously significantly lowering the curve by administering the vaccine earlier on. This is age. The cancer usually develops a little bit later in the 40s and 50s. So to drive the point home, unfortunately, our community is not immune to sexually transmitted diseases and HPV. From individuals and religious individuals are diagnosed with HPV-related cancers and precancers. In Israel, there was a study that looked at the rate of HPV and precancerous lesions, and it was really comparable to the rest of the Western world. And more specifically, there was a study that looked at sexually transmitted diseases among Orthodox women in a very Orthodox community in Israel. Surprisingly, what they found was that 12% of women had signs of previous chlamydia infection, and 6% of women had active chlamydia infection. Now, we know that other sexually transmitted diseases correlate with the rate of HPV infections. So the study did not specifically look at the rate of HPV, but it looked at the rate of other STDs that do correlate with the rate of HPV in the community. So it's not a small number. An additional survey of yeshivot in Israel, and among these Haredi yeshivas, super Orthodox yeshivas, 5 to 10% of teens admitted to intimate activity, which would put them at risk of being exposed to the HPV vaccine. And another thing to note, HPV can be transmitted through any skin-to-skin intimate contact, not just through intercourse. And people can be exposed from all various life experiences. And this HPV vaccine really does serve as a means to protect one from the HPV virus and cervical cancer. Thank you for listening. I wanted to switch gears now and talk a little bit about ovarian cancer. There are approximately 21,750 new cases estimated for ovarian cancer in the year of 2020, and it's estimated because the final numbers are not in yet.
All right, Dr.
The overall life.
We just have one more minute.
Oh, okay, so I'm going to have to go through this a little quicker. Overall lifetime risk is about 1.2%, and you can see the rest of the demographics here. What I wanted to highlight here is about 10 to 25% of ovarian cancers are thought to be due to genetic predisposition. Unfortunately, detection of ovarian cancer is not great, of early ovarian cancer, because the symptoms can be very vague, as you can see from this slide. Bloating, abdominal pain, weight changes, early satiety, changes in stool caliber, constipation, and discharge. These symptoms are so common, but the recommendation is if these symptoms do persist for greater than 2 to 3 weeks, they need to be investigated further and not ignored. Hereditary breast and ovarian cancer, was touched on briefly by J-Screen, accounts for about 10 to 25% of all ovarian cancers. As was discussed earlier, it is composed of mutations in genes that fix damaged DNA, and here is a list of examples of some of the genes that cause hereditary ovarian cancer.
Sorry to cut you off, Dr. Helmanastro, but that's our time. We have to move on to the next speaker.
Okie dokie. Well, these slides will be available. I did just want to make one last point, if I can go to my last slide.
Sure.
Okay, this is the basic take-home messages. Pap smears detect precancerous cells of the cervix and recommended for all women, and the HPV can prevent cervical cancer. Unfortunately, screening for ovarian cancer in low-risk patients, meaning if you do not have a genetic predisposition, at this time is not recommended. And screening for high-risk people is based on limited evidence. There are ways to decrease the risk of ovarian cancer, even in low-risk people, in the form of birth control pills. In high-risk people, there are ways to decrease it as well. And there is surgical intervention that is warranted to decrease the risk of ovarian cancer, which unfortunately I cannot get to, but these slides will, and I'm happy to answer any questions at the end with regards to this. I'm sorry that I ran out of time. And I do encourage people to participate, if they are at high risk, in clinical trials in terms of screening and prevention of ovarian cancer. Thank you.
All right, thank you so much, Dr. Helmanastro. Next, I'd like to present the following speaker, Dr. Miriam Knoll. Dr. Knoll is a board-certified radiation oncologist at Advanced Radiation Oncology, serves at Montefiore Nyack Hospital in New York. Dr. Knoll received her medical degree at New York University School of Medicine and completed her radiation oncology training at Mount Sinai Medical Center in New York. Dr. Knoll has expertise in advanced radiation techniques. Dr. Knoll is a Forbes healthcare contributor and writes for the American Society of Clinical Oncology Connection and numerous other media outlets. Dr. Knoll is president of the Jewish Orthodox Women's Medical Association. She's an international speaker and researcher with expertise in cancer care, social media and medicine, and women in medicine. Dr. Knoll lives with her physician husband and sons in New York. You can follow her on Twitter and Instagram. Thank you, Dr. Knoll.
Okay, thank you so much. I'm so excited. If you have heard me speak before, you know that I have a very bad cold, so I apologize in advance. It's not COVID. I am fully vaccinated, but it's just a really bad cold. So as you can tell, we're covering a lot tonight. Tonight, what I'm specifically covering are general screening recommendations for women in regards to colorectal cancer, otherwise known as colon cancer and rectal cancer or colorectal cancer, lung cancer, skin cancer, and also BRCA screening. So we're going to cover a lot. Yes, it's going to be very general. It's not going to be very specific, but the goal is that you have some education about screening for these cancers so that the next time you hear it, whether at your doctor's office or you're doing research on your own or you go to another lecture, this will sound familiar to you. So on that note, I'm going to go to my next slide. Here are my disclosures, not relevant to this talk. As we mentioned before, the information that we're sharing is for educational purposes only. So we usually get lots of questions in these types of talks. Please don't feel bad if we decide not to answer it. If you put a question in the Q&A that's very personal, it's because it's impossible for us to share a recommendation for a very specific case, but only for a very general one. So here are our learning objectives for tonight. So let's go straight into it. So screening for colorectal cancer, like I said before, colorectal cancer is a combination of two different cancers that we combine because the colon and the rectum are connected to each other. So it's colon cancer and rectal cancer. The screening for both are the same. And the main thing to understand about cancer screening is this. We want to screen for cancers that are common, that people are likely to get. And we also want to screen in a way that's effective. So sometimes people want to know, why can I get a scan every day? I want to know if I have cancer. And the second I know that I have it, I'm going to get treated. Well, the question is, well, what would that look like? What does screening look like for someone who really wants to know if they develop a cancer? Should everybody get a CAT scan every day? How about an MRI? How about a PET scan? How about a colonoscopy? So these are all the things that physicians like myself and primary care doctors and anyone who's interested in cancer screening, they want to know, well, how likely are we to find something and how confident can we be in those results so that until the next time, we think it's unlikely that a person will have developed a cancer in the interim. So for someone who wants to be screened for colorectal cancer, these are the recommendations. If you are of average risk, that means we're not particularly concerned that you're more likely to develop a colon cancer than any other person. And I'll explain more what that means. You should get screened starting at age 50. And how should someone like yourself who is at regular risk for colorectal cancer, how do you get screened? Well, here are your options: a colonoscopy, a stool-based test. That means that the actual stool, the bowel movement itself, is studied to look for blood, because if someone has a cancer, the cancer itself needs to be fed, just like every other part of your body, with blood, with nutrients, and those blood vessels are actually leaky. So if someone has a cancer, what happens is the bowel movement itself will have traces of blood in it. So colonoscopy, stool-based testing, a flexible sigmoidoscopy, which is similar to a colonoscopy, or CT colonography, which is a CAT scan. So I said this is for someone who is average risk. Who would not be at average risk? That would be someone who has a history of something abnormal in their colon, like a history of an adenoma, which is a precursor to a colorectal cancer. Someone who has a history of irritable bowel syndrome, I'm sorry, no, not irritable bowel syndrome. If someone has a history of Crohn's disease or ulcerative colitis, then they would be at a higher risk, or they wouldn't be at standard risk. And if someone has a family history of colon cancer, then again, this would not apply to them, and we would recommend earlier screening. So this is a screenshot of recommendations from the NCCN guidelines. I'll share the website a little bit later that has very detailed information about which test is reliable and for how long. So for example, if someone has a colonoscopy, that would mean that over the next 10 years, they're very unlikely to develop a cancer. So they don't need to get another colonoscopy for 10 years. But if someone has a flexible sigmoidoscopy, then we're a little less certain that we've done a very comprehensive screening, so you get one a little sooner. Same thing for CT colonography. So again, the colonoscopy is the gold standard. It's the best way to check, and it's the one that we rely on for the longest amount of time before recommending another one. And then at the bottom, high sensitivity guaiac-based tests, FIT testing, which is fecal immunochemical test, and stool DNA test. These are, like I mentioned before, the tests that look at the bowel movement itself to look for traces of blood. And these are actually done annually or every 3 years, depending on the test. So I had mentioned before that this all applies to someone who's at regular risk. Well, what if someone has a history of someone in their family having had a colon cancer? Well, in that case, we're more worried, and therefore we would want them to have a screening at a younger age, either at age 40, which is 10 years younger than when we usually recommend it, or 10 years before the earliest diagnosis. Well, what does that mean? Let's say your uncle, your brother, your sister was diagnosed with a colon cancer at age 45. So 10 years before would be 35. So we would want you to get a colonoscopy at age 35, which is 10 years before. Let's say you have a relative that was diagnosed at age 60. 10 years before would be age 50. But 50 is already older than the age 40 that we would usually recommend. So we would recommend that you get screened at age 40. So it's 40 or 10 years before the earliest diagnosis. So if somebody has inflammatory bowel disease, which is different than irritable bowel syndrome, which is by mistake what I said before, those are two very, 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 very different things. Inflammatory bowel disease is ulcerative colitis or Crohn's colitis. Both of these conditions have a higher risk of developing a cancer, and therefore, instead of waiting until age 50, we would want that person to be screened at a younger age, which is 8 years after the onset of their symptoms. Okay, so that was a very brief overview about colorectal cancer. And now I want to move on to lung cancer. So again, what we mentioned before is that, well, how does someone know if they have a lung cancer? Who should be tested for a lung cancer? Should everyone get a CAT scan every day? So these are things that, again, physicians, experts look at. And when they combine all the data, they make a decision based on what is the risk versus benefits. Well, is there a risk of getting a CAT scan every day of your life? Yes. Well, there's a small dose of radiation. There's also the cost of going. There's a cost to you of your life, you know, going and scan anxiety, right? The anxiety of getting scans, of finding things. And so what we've come to an understanding as a medical community is that those who are at a higher risk of developing a lung cancer, they should get screened. And this is relatively recent guidelines that, again, are in the NCCN guidelines. I'll share the website a little bit later. So for individuals who are 50 years old or above and who have smoked for 20 years or more, a pack year means a person has smoked a pack a day for a certain number of years. So if someone smoked a pack a day for 20 years, they have a 20 pack year history. If someone smoked 2 packs a day for 10 years, that would also be a 20 pack year history. And these individuals are recommended to have a low dose CAT scan specifically to look for lung cancer. Again, the point is to find the lung cancer when it's so small that you would only know about it if you found it on a CAT scan, instead of waiting and seeing if somebody developed it, you want to find it when it's earlier and more easily treated and curable. Some other things that are important that your physician may ask you in terms of your risk for lung cancer, aside from age and your history, are also occupational exposures. So some people are exposed to fumes or other kinds of dangerous chemicals or particles at work. Some people have a history of lung disease. Some people have, many people in their family have been diagnosed. Some people have been exposed. So secondhand smoke. All these things are things that could also be considered when deciding to whether or not, whether to recommend lung cancer screening, which again, by definition is a CAT scan. So not an X-ray, but a low dose CAT scan. The next thing I wanted to share in this general overview of cancer screening is screening for skin cancer. So skin cancers include melanoma, basal cell carcinoma, squamous cell carcinoma. People are at a higher risk for developing a skin cancer if they have the following characteristics. Number one, a lighter natural skin color. Skin that burns or reddens easily. So if you're more likely to get a sunburn, if you have pale hair, pale eyes, people in your family have had skin cancers before, or if you're older. So the United States Preventative Services Task Force, like I mentioned previously, this is an independent panel of cancer prevention experts who look and see should people get screened for this particular cancer or not. And in terms of screening for skin cancer, they've actually said, we don't know. We're not sure if people should get it or should not get it. Well, you could ask, well, what's the argument for not getting screened for skin cancer? Well, what is a screen for skin cancer? It's basically going to your dermatologist and having your dermatologist look at your skin, examine your skin. It's actually an appointment you have to make specifically. So most dermatologists will not do a complete skin check when you go and have a consultation for acne or a mole or something else, right? If you're coming for something specific, they usually won't do a full skin exam. But screening for skin cancer is an appointment that you make specifically with your dermatologist to do a skin screening exam of your skin. So this is something that personally, when I counsel my patients who come to me for follow-up, whether they've had a breast cancer or a colorectal cancer, and, like as part of what we call routine health maintenance, I recommend for my patients that have pale skin that they should get a screening for their skin cancer, again, because I think that we don't have recommendations against it, and I think that the benefit is high and the risks are low. It's not invasive. It's very easy to do. And it's not hard to find a dermatologist to do this. So I do absolutely recommend making an appointment with your dermatologist once a year to get a skin screening. And the last overview I wanted to talk about tonight is BRCA. Now, why am I including it in this talk about general cancer screening for women? Because our audience is Ashkenazi Jewish women. And anyone who is Ashkenazi Jewish has a risk of having a BRCA1 and BRCA2 mutation, and that can increase the risk for different kinds of cancers. So I think it makes sense in a talk about general cancer screening, where my audience tonight is Ashkenazi Jewish women, to mention this. And there's a lot of confusion about it, which I think comes from a good place because people are a lot more aware of it. So I want to share just some general information about it. So number one, everyone, every single person in the world has 2 copies of BRCA, BRCA1 and BRCA2. And what they do normally in the body is stop tumors from growing. Okay, so you should know your body every day fights cancers. Every single day, every person in the world, your body grows, your cells grow. And whenever something isn't absolutely perfect, the body has a natural immune system, a way to surveil, to check and stop abnormal cells from growing, right? It's quality control, QA. And 1 in 40 Ashkenazi Jews has a mutation in the BRCA1, BRCA2. So instead of acting normally as they should, Instead, one of them is sort of broken. It doesn't work correctly. And if you don't have the quality control at working at its best, that means some things might slip through. And that's the reason why individuals who have a mutation in BRCA1, BRCA2 don't suppress tumors as well as they should. And therefore, sometimes cancer cells develop, slip through that quality control system, and then turn into a real cancer. But that being said, there's still one normal copy, and not everyone who has a BRCA1, BRCA2 mutation will get cancer. So it's something that when we think about, it's important to realize it's not about being 100% sure about developing a cancer. It's about having a higher risk of developing a cancer. Every person in the world can get a cancer. Someone who has a BRCA mutation has a higher chance of developing a cancer. And certainly, if someone who is Ashkenazi Jewish, like I mentioned, 1 out of 40 Ashkenazi Jews will have this mutation, and it can be inherited from the mother or the father. Sometimes people think it can be only from the mother. That is not true. It can be passed down from the mother or from the father. So what are the risks of developing a cancer? A breast cancer or an ovarian cancer, which are the highest risks of cancers developing from a BRCA1 and BRCA2 mutation. There are around 70% risk of developing breast cancer and around 44% risk of developing an ovarian cancer, depending if it's a BRCA1 or a BRCA2 mutation. Again, what that means is that the other percentage, right? So 30% of women who have a BRCA1 or BRCA2 mutation will not develop a breast cancer. And more than half of women with a BRCA1 and BRCA2 mutation will not develop an ovarian cancer. Why would somebody get tested for BRCA1, BRCA2 mutation? This is a very important question. So the answer is that testing should be done if the person wants to get tested and if having that information is going to be useful to them in their life and how they're going to decide to take care of their health going forward. And
Dr. Hill, just a 1-minute warning.
Thank you. So this is the United States Preventive Services Task Force, which I mentioned earlier about skin cancer. This is a publication they wrote specifically about BRCA mutation. Here is a website that I had mentioned previously that has all these complicated guidelines if you're interested. This is also from the NCCN guidelines, talking about all the things that somebody should do if they're going to get tested. Well, what are you going to do with those results? You're going to have a discussion about it. You're going to interpret the results. You're going to talk about the impact on the family. You're going to have that person meet with a genetic counselor to create what's called a pedigree. It's basically a family tree that shows who had cancer, what type of cancer, at what age. Was it a mother? Was it a grandmother? Was it on the father's side, to sort of see what the risks are potentially of that person developing a cancer and what they should do if they test positive. Here's some more guidelines about who should get tested. It's quite clear if you go through these guidelines. I'm going to recap here that an Ashkenazi woman who was diagnosed with breast cancer or an Ashkenazi man diagnosed with prostate cancer should get tested. And then any woman with an epithelial ovarian cancer, any man or woman with a pancreatic cancer should get tested. So there are lots of patients who have breast cancers who are getting breast cancers, pancreatic cancers, ovarian cancers who are getting tested. And again, the reason why people are getting tested is not just so that they know that they have BRCA1, BRCA2. It's because there are things that you can do about it. There are things that you can do, like get more breast exams, get more breast MRI, like I mentioned earlier. Why doesn't everybody get a CAT scan, an MRI, a mammogram every single day just to check if there are cancers? Why? Because that's crazy, right? You have to be able to live your life. What we want to do is encourage people who are at higher risk to get tested more frequently. And as an example, someone who has BRCA1, BRCA2 is one of those people who would want to check more often because their risk is higher. I just want to mention briefly that if you do have a concern about getting tested, the first thing you should do is make an appointment to see an oncologist or a genetic counselor. There's no reason to go online, Amazon, get a 23andMe test. Why? because you're not going to get the information that you want, right? It's not going to be a comprehensive review of your family history. It's not going to be a comprehensive review of all the cancer genes that you may be concerned about. You're not going to get the counseling that you need. You're not going to get the guidance that you need. It's really just a waste of time. If you actually are concerned, and you probably have a good reason to be concerned if you are Ashkenazi and you have cancer in your family, see a genetic counselor. I can't remember the last time that a patient was refused based on insurance. The insurance companies have really come around, they cover it. So that's something that, there's really no point in doing an at-home test when you can have a real professional help you and guide you. And here is my contact information. Thank you so much.
Thank you so much, Dr. Knoll. We're now joined by our sponsor, Invitae. Presenting on behalf of Invitae is Ms. Sherry Boyer.
Just give me a second. Thank you. Okay. Good evening, everyone. My name is Sherry Boyer, and I'm a clinical science liaison at Invitae and a genetic counselor by training. On behalf of Invitae, we are delighted to sponsor tonight's webinar on cancer screening and prevention and to support the important work of the Jewish Orthodox Women's Medical Association. So here are my disclosures. I'm an Invitae employee and shareholder. So Invitae is a San Francisco-based genetics information company and laboratory that was founded 10 years ago with a bold mission, and that is to bring comprehensive genetic information into mainstream medical practice to improve the quality of healthcare for billions, yep, I said billions of people. Our online address, invitae.com, is here, and we invite you to check out our website. It contains lots of patient-friendly information and videos about genetic testing and how genetic testing can help you and those you care about through all stages of life. At Invitae, we're guided by 4 core principles. The first relates to cost. By driving down the cost of genetic testing, it can be accessed by more people who can use the information to improve their health. Genetic testing has historically been very expensive, between $5,000 and $25,000. Cost has been a huge barrier, and as a result, only a small fraction of people who would benefit from genetic testing have in fact received the testing. Advances in technology have drastically reduced the cost of running a test. And in Invitae, we have passed these savings to the healthcare industry and to patients. While many people are covered by insurance, in Invitae, there is a $250 self-pay price, no matter how many cancer genes are being analyzed. The second principle is that healthcare professionals are fundamental in ordering and interpreting genetic information. Third, people should own and control their own genetic information. Fourth, and incredibly important, genetic information is more valuable when it's shared. And in Invitae, we introduced the concept of no-cost testing to family members of an individual who is tested by us whose result is positive. So this extends to all biological family members as long as they order their test within 90 days of their family member's result. And we've expanded this to 150 days during COVID. Unlike other laboratories, Invitae has an international presence, including a lab facility in Israel. This allows us to help family members overseas on all continents take advantage of our no-cost family variant testing. Oops. Sorry about that. So historically, access to high quality diagnostic grade genetic testing has been challenging. And we've simplified this process, whether testing is pursued through a personal physician or if a person is interested in testing, but her personal physician does not offer genetic testing through their practice. So how does this work? So pretty easy. Step 1 is either speak to your doctor about being tested, or you could request a test online and we would link you with a telehealth clinician to discuss testing. Then a saliva sample, a kit for a saliva sample is sent to you, and you can provide the sample from the comfort of your home and then ship it back to our laboratory and using a prepaid label. Then you would get your test results and share them with your doctor. And if you'd like, talk to a genetic counselor at no extra cost.
Sorry, Ms. Boyer, just one more minute left.
Sure. So what's included? We have a comprehensive menu. We offer 50 comprehensive tests, actually more than that, each of which includes genes that are relevant to specific types of cancer. When the results come in, we provide clear next steps so that you and your physician can take action based on your genetic test results. Then experts are available to you by phone to answer your questions. Once you have your results, you can also schedule a full genetic counseling session at no additional charge with one of our board certified counselors. So I was very happy that all of my co-presenters have mentioned this, and that is that not all genetic testing for hereditary breast ovarian cancer is equal. Testing through laboratories or through services such as Ancestry Services or 23andMe may result in a false negative test result or a false positive test result. So the best way to get your genetic information is through a diagnostic grade laboratory, which will have the offerings you need and the regular oversight that you want. So thank you so much. We really appreciate the opportunity to sponsor tonight's program.
Thank you so much for that. All right, now I'd like to introduce our last speaker, Dr. Rebecca Gams. Dr. Rebecca Gams obtained her undergraduate degree from Columbia University and earned her medical degree from the Albert Einstein College of Medicine in Bronx, New York. She was elected to Alpha Omega Alpha Honor Society upon graduation. Dr. Gams completed her residency in diagnostic radiology at Montefiore Medical Center in Bronx, New York. She also did a fellowship in breast imaging at Montefiore Medical Center. Dr. Gams is an attending physician at Hackensack University Medical Center in New Jersey and specializes in breast imaging. She lives in New Jersey with her husband and children. Thank you for joining us, Dr. Gams.
Thank you so much for the introduction. It's really an honor to be here with everyone tonight. I'm going to be talking to you about screening for breast cancer, which is something that I do as a radiologist every day. So our learning objectives tonight are to talk about screening mammograms, breast density, risk factors for breast cancer, and supplemental screening options. A few important facts. All women are at risk for breast cancer. Approximately 1 in 8 women will develop breast cancer in her lifetime. Breast cancer is the second most common cancer affecting women. It's second to skin cancer. Another important fact, most women with breast cancer do not have a family history of breast cancer. Most breast cancers are not hereditary. Breast cancer can be curable if detected early, and mammograms have been proven to decrease mortality from breast cancer by about 30%, meaning mammograms have been proven to reduce a person's risk of dying from breast cancer by 30%, which is a huge risk reduction. What is a mammogram? Here's an example of a mammogram machine. A mammogram is an X-ray of the breast. People who don't have any symptoms will come for a screening mammogram, usually when they turn 40. That's what we recommend. And we want them to come get this X-ray so that we can detect breast cancer when it is small. We want to detect the cancer when it's small and before it has spread to the lymph nodes, because that will allow for the greatest chance at survival, and also will allow for better treatment options where a patient could have a lumpectomy instead of a mastectomy, also to hopefully decrease the chance that a woman would also need chemotherapy. So there's a debate as to when women should begin having their annual screening mammograms. The American College of Radiology, Society of Breast Imaging, the NCCN, we all agree, we all recommend that women should start at age 40 and have them annually going forward. The American Cancer Society says women should discuss with their doctor between age 40 and 45, but they should start at 45. And the USPSTF recommends that women should start at age 50. Although there are different opinions as to when women should start, all the societies agree that starting at age 40 will save the most lives. So that being the case, our recommendation is to start at age 40 to save the most lives. Now, when should a woman stop getting a mammogram? There's no set age. Really, what we recommend is as long as a woman has a 10-year life expectancy, then she should continue getting her mammograms. So if she's in good health, there's no reason why she should stop having a mammogram. So what to expect when you go for a mammogram? you'll meet with a radiology technologist who will position the breast between compression paddles. And compression is really what gives mammograms a bad name. People don't like the compression. It can be painful, it can be uncomfortable, but I'm going to explain why the compression is necessary, and hopefully that'll make it more tolerable. So we use the compression to flatten out the breast so that we include all the tissue in the field of view. We also want to spread out the tissue to limit overlapping. If we spread out the tissue and we compress the breast, we can use a lower X-ray dose. We can also hold the breast still, and we can reduce X-ray scatter to keep the image sharp. So for all those reasons, compression is really very important. When the technologist does the mammogram, she'll do 2 views of each breast. One view from top to bottom and one view from side to side of each breast. And a standard 2D digital image is basically a single flattened image, and that was basically the standard of care until 2011. In 2011, the FDA approved digital tomosynthesis, 3D mammograms. So what is a 3D mammogram? A 3D mammogram is tomosynthesis. It uses multiple low-dose X-rays taken from different angles to create a 3D image of the breast. Basically, it allows the radiologist to look inside the breast layer by layer. We can see more fine details. We can minimize the overlapping tissue so that we can reduce our recall rate. And we can also help detect cancers that otherwise would have been hidden by normal breast tissue, because we're looking at it slice by slice. We're not looking at a single flattened image. This is especially useful in women with dense breasts. And as I mentioned before, it can reduce the recall rate because we're looking layer by layer individually. So tomosynthesis has really become the new standard of care. So when women ask all the time, should they go to a place that offers tomosynthesis? I say 100% yes. If you're making an appointment for a mammogram, make sure that you're going to get a tomosynthesis mammogram, because it's much more powerful than a standard 2D mammogram. It also can increase the cancer detection rate by about 1.2 to 2.7 per 1,000 screening exams. So here's an example of a tomosynthesis of mammogram. Here's the 2D image, standard 2D image. Everybody sees here, there's a density here, really indeterminate. And now here's a slice from a tomosynthesis series. And if you look very closely at your monitor, you can see that there are little lines coming out from this density, little spicules. And this makes this density very, very suspicious for cancer. Sure enough, we biopsied it and it was a cancer. So here, it's there, you see it, indeterminate. Here, really, really suspicious. So tomosynthesis is very helpful for us. Okay, now another issue that people have with mammograms is that it's radiation. People are afraid of radiation. People don't want to submit themselves to radiation if it's not necessary. So I'm here to tell you that the radiation dose of a mammogram is very small. The approximate dose is 0.4 millisieverts. For comparison, a cross-country plane trip is 0.04 millisieverts. So a mammogram is about 10 cross-country plane trips. People travel for business all the time. People don't think twice about the radiation involved in a plane trip. You just take it, you don't even think about it. It doesn't really affect you at all. So too, a mammogram should be the same. And if you look at other diagnostic imaging, like a CAT scan of the head is 2 millisieverts, also much more than that mammogram dose, and a CAT scan of the abdomen and pelvis is 10 millisieverts. Again, much more than the mammogram. The mammogram is really low dose, and it shouldn't be something to worry about. Here, I'll explain again that their modeling studies have tried to figure out what a theoretical risk of the mammograms causing a cancer. If women getting mammograms every year from, let's say, 40 to 74, so for 34 years, how many of those women will get a cancer because they had radiation from mammograms? So here, modeling studies show that 125 cases of a radiation-induced breast cancer per 100,000 women. That's basically 1 in every 1,000 women may develop a cancer just from having 30 years of mammograms. And of those people, 11 of those 125 who get the cancer will die. So really, 1 in 10,000 women may die from a cancer induced by a mammogram. That number is so small. And if you remember what the number of the possibility of getting a cancer in a lifetime, that's 1 in 8. So 1 in 8 women, 12% chance of getting breast cancer. It's so important to get that mammogram to catch the cancer early. The data is clearly showing that the benefit from the screening mammogram clearly outweighs any theoretical risk of the radiation from the mammogram itself. Okay, so now you have your mammogram, and there are two important things in your report. Number one is going to be the breast density, and number two is going to be whether your mammogram is normal or abnormal. So I'm going to talk a little bit about breast density now. What is breast density? So the breast is composed of fibrous tissue, glandular tissue, and fatty tissue. So if someone has dense breasts, that means that they have a lot of fibrous or glandular tissue and not so much fat tissue. The dense tissue is white on the mammogram, but masses are also white on the mammogram. Those include benign masses like cysts or fibroadenomas, which are benign masses. Those are white, but cancers are also white. So if someone has dense breasts, that means they have a lot of white tissue on their mammogram. It's going to be very hard to spot that white cancer in the sea of their white tissue. And another thing, dense breast tissue is a small independent risk factor for breast cancer as well. So let's look at examples of mammograms. So these are the side-to-side views. Here's the breast, the nipple is here in the front. Here's the pectoralis muscle, and up here is the axilla or the armpit. So this is what we call a fatty mammogram. There's very little of that white tissue, and about 10% of the population will have a fatty mammogram. This here is a scattered mammogram. Again, a little more of that white tissue, but still pretty fatty, and that's about 40% of a population. So these are the non-dense categories. And now over here we have the dense categories. Here you see there's a lot more of that white tissue, and here it's like a wall of white tissue. This is heterogeneously dense, about 40% of women, and extremely dense is about 10% of women. You could see how a small cancer can be hiding in all this white tissue. And that's why the tomosynthesis is really so helpful, especially in dense tissue. When you're looking at layer, it'll be easier to spot the small cancer. Another thing about breast density is sometimes women with a higher body mass index may be in the non-dense category. Also, women as they get older may, even if they were dense when they were younger, they may go into a non-dense category. Women, when they're pregnant or lactating because of all the hormones, they can be very dense. So 1 year you could have a woman who's breastfeeding, she'll be very dense, but the next year when she's no longer breastfeeding, you'll see that there's a change in her breast density, and her breast density may go down because of that. So here are different examples of the breast density. So now breast density is important because in 2009, Connecticut was the first state to enact a breast density law, which requires patients and referring physicians to be notified about the fibroglandular pattern of their patients. Why? Because someone with dense breasts has to know that A, she's at an increased risk for breast cancer, and B, her mammogram may not be as good as someone who has a fatty breast. And these women with dense breast tissue may benefit from other screening tests. So I said in 2009, Connecticut was the first state. Now we have 37 states and Washington, D.C. all requiring it. There are other states that are in the works, and also the federal government is also working on a federal breast density legislation. Okay, so for supplemental screening, what are our options? So someone has dense breasts, what should she do with it? So she could get a screening ultrasound. Ultrasound uses high frequency sound waves. There's no radiation. It's inexpensive. It's well tolerated. It's not a very long exam. It's performed either by a technologist or a radiologist, or some places have an automated device that does the ultrasounds. And ultrasound can find an additional 2 to 4 cancers per 1,000 women already screened by mammography. The downside to ultrasound is that it will show other benign masses, which may require biopsy or follow-up. But now ultrasound is really our second best thing for women with dense breasts. The mammogram is necessary, even though it's not as good. It's still necessary. You cannot get rid of the mammogram, and ultrasound would be the second test to do. Another test that can be used, here's an example of ultrasound. This is what normal breast tissue looks like. And here you see this is a cancer. It's much darker, it's blacker than the normal breast tissue. And if you look here at the margins are very irregular. This is very suspicious and it is a biopsy-proven cancer. Okay, MRI. MRI can also be used to screen women for breast cancer. MRI uses magnetic fields and radio wave pulses to create an image of the breast. It requires an IV with injection of gadolinium-based contrast, which is a heavy metal. MRIs are very expensive. They're not well tolerated. Some women are claustrophobic. It's a long exam. It's not a comfortable exam, and it's not used for screening for dense breasts at this point. It's really only used for screening for high-risk patients, and a lot of that has to do with the insurance companies also, that they don't want to cover it because it's so expensive. But MRI is really the most sensitive test for detecting breast cancer. It can find an additional 10 cancers per 1,000 women screened by mammogram. The downsides, it can show other benign things which may require biopsy or follow-up. Here's an example of an MRI. The white that you see, that's the contrast, and here you see this cancer picking up all that contrast. So MRI really now is used in the high-risk population, but there is a lot of research being done to try to make MRIs shorter by doing fewer sequences, make it less expensive, and also if it's shorter, it can be better tolerated. So in the future, it may be used for screening for dense breasts, but at this point, it's really only in the high-risk population. Okay, so the
Sorry,
second
Dr.
thing
Graham, just a 2-minute warning.
Okay, the second thing in the mammogram report is we have normal versus abnormal. So this is very anxiety provoking. A lot of women are worried when they get a mammogram, are they going to be recalled? So of 1,000 women, 100 will be recalled, 10%. Of those, 81 will be negative, 19 will have a biopsy, and 5 will have cancer. So 5 out of 1,000 who have a screening mammogram will have cancer. Risk assessment, who and why. So all women before the age of 30 should have a risk assessment so that we can detect cancers at earlier stage, have better treatment options, greater likelihood of survival. These are all the risk factors for breast cancer. The most important risk factor is being a woman. The second most important risk factor is age. As women get older, their risk for cancer increases. Women over age 50 are at a higher risk. Ethnicity, Hispanic women, African American women can present earlier. Also, exposure to hormones, estrogen and progesterone. So if you have your period before 12 and menopause after 55, you're at higher risk. If you have a late first pregnancy or never had a pregnancy, you're at a higher risk. Obesity, alcohol use, smoking, those are all increase your risk for breast cancer, but they keep you in the average risk. Other risk factors are prior radiation exposure, like someone who had Hodgkin's lymphoma as a teenager or young adult and had radiation, she's at a higher risk. Having a higher prior biopsy with a high-risk lesion. And then family history is really very important. And in family history, you want to know how old that family member was when they were diagnosed with breast cancer. If there's a gene mutation, the degree of relationship, really if it's a first-degree relative, sister, mother, daughter, history of premenopausal cancers, how many people were affected, and male breast cancer and ovarian cancer. So average risk, less than 15% lifetime risk. That's no personal history of breast cancer, no mutation, no history of radiation. All the hormonal stuff, all this other stuff is still average risk. Intermediate risk is 15 to 20% chance, personal history of breast cancer and a prior biopsy with a high-risk lesion. These people may benefit from MRIs. And then the highest risk is a greater than 20% lifetime risk. And those are the BRCA mutations, the history of radiation therapy to the chest, in like a Hodgkin's case, and other genetic diseases. These patients with the BRCA gene, about 6% of breast cancers are caused by these mutations. Average age of onset of cancer is much lower than the general population. And 55 to 65% of women with BRCA1 will get cancer and 45% with BRCA2. And these patients need annual screening MRIs starting at age 25. Starting at age 30, they should have a mammogram and MRI. Again, discuss risk-reducing mastectomy with their doctors and screening for other associated cancers, as Dr. Knoll mentioned. I want to end just because this is a hot topic now, the COVID vaccine and mammograms. So the vaccine is given in the arm and it can cause swollen lymph nodes in the armpit, the axillary lymph nodes. That's a normal immune response. But we see these lymph nodes on a mammogram, and sometimes, very rarely, cancer can only present in the lymph nodes. Again, it's very rare, but that's why we look at the lymph nodes, and that's why when we see big lymph nodes, it sends a warning sign. But if we know that a woman just had her vaccine, and she just had her vaccine in that arm, then we're likely to think that her swollen lymph nodes are really only due to the vaccine. And because of this issue, the Society of Breast Imaging put out a recommendation for women due for their screening mammogram that it's best to get the mammogram before the vaccine so we can avoid looking at these enlarged lymph nodes. And if not, they can delay their screening mammogram for 4 to 6 weeks after the second dose of that vaccine. This is not necessary. It's not a contraindication to get your mammogram right after your vaccine. It just will avoid looking at big lymph nodes. Here's an example of the lymph nodes. This is a mammogram January 2020. These are the lymph nodes. Nice small lymph nodes. This is January 2021, 2 weeks after the patient, this is a right breast. She had her vaccine in the right arm 2 weeks prior to this mammogram. Again, you see, same patient, the lymph nodes are much bigger this year, but it was the same arm. It was 2 weeks after her vaccine. This is likely just a reaction to the COVID vaccine. And we're gonna bring her back in 3 months and her lymph nodes will probably be back to normal. So this is just something hot off the press. There are some key points. 1 in 8 women are going to be diagnosed with breast cancer during their lifetime. Mammograms save lives. Mammograms are safe. Know your breast density and your supplemental screening options, and know your risk for breast cancer. Thank you.
Thank you so much, Dr. Gams. We now actually would like to go back to Dr. Helman Ostrov just so she can finish her presentation.
Okay, let me just, thank you very much. I'm just going to pull up the rest of this. Just bear with me. Okay, so thank you for inviting me back to talk a little bit more. I did want to go a little bit more detail about the ovarian cancer and ovarian cancer screening. Some of this fortunately was covered both by Dr. Gams and Dr. Knoll, which limits how much I need to repeat this, so thank you. But I did want to talk about this because a lot of people are concerned about it and there's a lot of buzz talking about ovarian cancer, and it is a scary disease, and therefore gets people very, very concerned. I just want to re-emphasize, in the general population, the overall lifetime risk of ovarian cancer is about 1.2%, with about 22,000 cases diagnosed annually in the United States. The difference between the ovarian cancer and breast cancer, though, is that a significant higher proportion of ovarian cancers are genetically related. 10 to 25% of ovarian cancers are genetically related, as opposed to breast cancer, where it's more in the range of 5 to 6% are genetically related. Again, I touched on this briefly. Symptoms of ovarian cancer are unfortunately very vague, which limits our ability to detect it early. As you can tell by this list, all of us have experienced some of this at some point. The key point here is that if these symptoms persist and do not have any other underlying cause and last longer than 2 to 3 weeks, you really should present it to your doctor for an evaluation, just to take a look and make sure that it is nothing concerning, but it by no means defines or diagnoses cancer. A little bit about hereditary breast and ovarian cancer. Like I stated, it accounts for about 10 to 25% of ovarian cancers, and composed of these genes that Dr. Knoll, as well as other speakers here, have spoken about. A list here is the BRCA genes and some, this is not a fully inclusive list, some of the BRCA-related genes that can predispose one to developing ovarian cancer. Down here. Now, because ovarian cancer is such a concerning disease, there have been huge studies looking at different ways to try to screen for ovarian cancer, similar to Pap smears for cervical cancer and colonoscopies for colon cancer. Unfortunately, we have not been successful in coming up with a safe and effective way to screen for ovarian cancer that is in the general population. 2 very large studies, each study included over 100,000 women split up into different groups, found that doing screening with ultrasounds and blood tests known as CA-125 did not decrease the deaths related to ovarian cancer. And unfortunately, on the flip side, did cause some harm. In one of the studies that was conducted in the United States, about 15% of women who were screened ended up with complications from surgery that they did not necessarily need because they did not end up having ovarian cancer. So when we look at screening tests, we really have to look at what is the rate of cancer detection and what is the rate of harm that is done to people who do not have the cancer as a result of this test. So based on this, the U.S. Preventative Screening Task Force stated that screening in low-risk patients is not warranted. And to just give you a brief understanding of maybe where the difficulty lies, this is an ultrasound looking at ovaries. So on the left, you see this is an ovary with all these like patterns in it, some areas that are white here, which would indicate a solid area, and some areas are black here, which would indicate a liquid area. And then you look at this one on the right, which also has a solid area and a liquid area. Do they look identical? No. But do either of these look like just a big water balloon, which would be a big black balloon? No. So obviously this can be subject to interpretation and is not so straightforward in terms of detecting if something on the ovary is cancerous or not. This was covered previously, but just to go over the ovary risk, with a BRCA mutation or BRCA mutation. In BRCA1, the overall lifetime risk of developing ovarian cancer is 39 to 46%. And in BRCA2, in BRCA2, it is 12 to 20%. And the risk of breast cancer was already previously discussed. Now, screening for ovarian cancer in high-risk patients is different. Screening for ovarian cancer can be offered to high-risk patients who still want to have children and keep their ovaries and their uterus in. Therefore, the recommendation in someone who has a mutation is between the ages of 30 and 35. We don't usually recommend screening earlier than that because, as you saw from the previous slide, the average age of cancer development is 45 to 50 and up. There was a recent update. Okay, the recent update from a large trial did indicate that we may be coming up with some ways to screen better in high-risk patients to detect early ovarian cancer. Now, the best form of early detection is prevention, as discussed previously. In the general population, even though we don't have great screening mechanisms, there is a way to decrease the risk of ovarian cancer overall. And studies have found that 5-year use of birth control pills will significantly decrease the risk of ovarian cancer in the general low-risk population. And in women with BRCA1 and BRCA2 mutations, it decreases the risk of ovarian cancer significantly by 50% and 60%. The issue with this is the risk of breast cancer related to prolonged use of birth control pills has not been clearly defined. So that needs to be weighed very carefully when discussing prevention with birth control pills in people who are high risk of developing breast cancer. Surgical prevention is one of the most effective means that we have in decreasing the risk of developing ovarian cancer in patients and people who have a known significant increased risk. People with a BRCA1 mutation, the recommendation is to remove the fallopian tubes and the ovaries ages 35 to 40, and BRCA2 is 40 to 45 based on the risk factors of when the cancer is most likely to develop. This decreases the risk of ovarian cancer by 80 to 90%. It's not 100%, but it is very effective. There have been some controversial studies looking at surgery intervention. There's something called the WISP trial where fallopian tubes were removed and ovaries were left in to prevent early menopause. Results of those studies are still pending. And removal of the uterus is also a controversial topic in surgical intervention to decrease the risk of cancer in BRCA1 and BRCA2 mutations. And that's a very complicated, long discussion. I usually spend about an hour discussing it with patients. So future directions, fortunately, we do have some things cooking to try to help looking at detecting early ovarian cancer. This is various blood tests. Circulating mRNA is something that's being hotly investigated. Some other markers as well. And I would encourage anybody who is at no particular high risk to enroll in clinical trials to help us in terms of screening and early detection of ovarian cancer, both in high-risk people and in the general population. I discussed this slide previously. If you have any questions, feel free to ask me, but I don't want to waste your time and repeat it. So thank you for the time.
Thank you so much, Dr. Hellman. We just want to thank all of our speakers. I want to acknowledge Dr. Denise Moses, Jackie Benayoun, Dr. Sahar Wertheimer, Miriam Andrusier, Nicole Feigenbaum, and Tamar Iskowitz for organizing the event, and Dr. Abigail Rapp for joining us as panelists. We are now about to start the Q&A. We'll begin the Q&A with this first question, but please keep in mind that this is not medical advice. Our first question is asking, can you discuss population screening for BRCA? Is this something you think the FRUM community should embrace? And if so, how do you recommend doing so?
I could take that one.
Yes, yeah, I do want to start us off. Thank you.
Yeah, so the carrier rate of a BRCA mutation in people who are Ashkenazi Jewish, as you all know, is very, very high. It's about 10 times the general population risk. And studies have shown that the cancer rate is going to be the same in a carrier, whether or not they have a personal or family history of cancer. So there definitely are really good reasons to test people who are Jewish just because they're Jewish, not even necessarily because there's a history in their family. That being said, anyone who wants to get tested should just, think about it before they do so. They have to, weigh the risks and benefits. Obviously, the benefits is doing, some kind of intervention to try to reduce the chances of getting cancer or to catch it at an early stage. You'll have the option of doing IVF if you're still thinking about having kids at that point. But some risks to doing it are obviously in the shidduch world. It's, could be difficult for somebody who finds out that they're positive when they're, dating on the dating scene, because it could, as you can imagine, be an issue for some guys. So that's something to consider. If somebody does have a history or there's a good reason to think they might be positive, we always recommend that they consider doing it once they're already in a committed relationship. If they're already getting a little bit older and they're not married yet, I do think they should get tested just because they need to be safe medically. There are also issues with insurance. Sometimes there are certain types of insurances that people could be discriminated against if they're positive for a BRCA mutation. So we don't recommend that young people, necessarily get tested right away. So there's, pros and cons of getting tested. And I'm happy to talk to anybody about it on a personal level if anybody wants to. I hear this all the time. But there's definitely a good reason to get it done, even if you don't have a history yourself or in your family.
Thank you so much, Esty. So our next question is about breast exams. Specifically, should women be performing their own self-breast exams? And then kind of grouped into that question, is there a way to know if you have dense breasts? And can you speak about self-exams and red flags?
Okay, so self-exams are really a controversial topic. Some people are all for them, and some people say they're really worthless because they're just going to create a lot of anxiety. I think if you do choose to do a self-breast exam, you should try to do it the same time of the month every month, meaning like if you day 1 of your period or day 8 of your period, but always do it at the same point of your menstrual cycle. So that way, what your breasts feel like. Your breasts can change over the course of your menstrual cycle. So always do it at the same point. If you do it and you have a problem, the first step would be to go to your doctor and have your doctor examine you as well. Red flags for a breast exam, a self-exam, would be a hard mass and a mass that doesn't move. Those would be, concerning signs that you should definitely go see your doctor. Was there another part to the question?
Yeah, how do you know if you have, is there a way to know if you have
dense breast? So no, you don't know if you have dense breast until you have your first mammogram. Generally speaking, younger women tend to have dense breasts, but there are plenty of women who get their mammogram at 40 and do not have dense breasts. So really you don't know until you have your first mammogram.
Okay, thank you so much, Dr. Gams. The next question is about cervical cancer screening. Can you speak about pap smears and transmission if you have never had sexual activity?
Okay, I'll be happy to answer that question. So traditionally speaking, HPV is transmitted through relations and skin-to-skin contact. There was a very famous study, which was a study of a monastery where nuns theoretically had zero sexual contact, and the rate of cervical cancer was non-detectable. That being said, people oftentimes confuse the fact that HPV transmission can occur with skin-to-skin contact without full intercourse. And that's sometimes misunderstood, and people think that they are not at risk just because they have not had full intercourse, and that's where the problem lies. So in general, the recommendation is for someone over the recommended ages, either 21 or 25, based on the screening modality that you're using, to be screened for cervical cancer as a safety mechanism. There are very, very rare forms of cervical cancer which are not HPV related. And that's another thing to be aware of, that even as someone who has not been sexually active at all still needs to see a gynecologist, because these conditions do occur, albeit rare.
Thank you so much. This next question may also be for you, Dr. Helman Ostrov. Can you discuss screening for uterine cancer?
Right, so unfortunately, we had a limited amount of time during this talk, as you saw from some of the back and forth. So uterine cancer, really, the screening for uterine cancer is specific for people who are high risk of developing uterine cancer. It is not a recommended screening test in the general population, unlike pap smears or colonoscopies or other screening, or mammograms, or the screening modalities that we talked about. So if someone has a known high risk of uterine cancer, or someone thinks they're at high risk of uterine cancer, they need to discuss that with the gynecologist to see whether or not they qualify for testing, but it is not recommended in the general population.
Okay, thank you so much. And then the last question was about the HPV vaccine. Someone could just kind of comment about like when it is and when typically women should get the vaccine.
I don't know why I keep on turning off the video. I should just have left it on. But so the HPV vaccine, I touched on it very briefly because it's a very long talk and discussion, but recommendation for administration actually it can start as early as the age of 9 to the age of 11. It's recommended to be administered in young adolescents. And the reason for that is not because we think young adolescents necessarily are going to get HPV, but it's because the immunity that is developed for these vaccines is much stronger if the vaccines are administered early on, and it provides longer immunity. We do recommend that everybody gets the HPV vaccine. It is highly effective with a very, very, very stellar safety record, with many years of study, with millions and millions and millions and millions of doses being administered and published internationally. So I would highly recommend it.
I just wanted to add to the question about what are some warning signs for breast cancer. So other things that women should be concerned about are breast pain that doesn't go away. Most breast cancers are not painful, but occasionally they can be. Any reddening of the skin, so over a few days or weeks or months, the skin over the breast gets very red. Even if it happens slowly, that's something to be concerned about. Any change to the shape of the breast, feeling something hard in the breast, like a lump or something that feels stuck, any nipple discharge. So basically any change to the breast would be something to see your primary care doctor, gynecologist, and have examined. So any changes at all should not be ignored.
Thank you so much, Dr. Knoll. One final question is how much more radiation is the tomograph mammogram compared to the 2D mammo?
Yes, that's a great question. So there are two ways to do the tomosynthesis. One way to do it is, you take those multiple low projection images and then you synthesize a 2D image. So then it's basically the same, maybe a teeny bit more than a regular mammogram, but really very similar. The other way to do a tomosynthesis mammogram is to take your tomosynthesis and then to do a complete separate 2D mammogram, and that would be double the dose. Most places nowadays are doing the first way I talked about, where they're synthesizing a 2D image, which keeps the dose pretty equivalent to a regular 2D digital mammogram.
Hi, all right. Thank you everyone so much for your time, and thank you to all our registrants. Thank you so much to our panelists for doing such a thorough webinar on cancer prevention and screening. And thank you to our sponsors, JScreen and Invitae. We also want to thank our friends at Men Together for everyone helping to make this such a successful webinar. JOWMA is a nonprofit organization and a free community resource. Everyone who spoke today has done this out of the own time that they have and as a volunteer. So if you'd like to donate to JOWMA, please check the chat box for the link. And please scan the QR code so that you can fill out both the pre and post webinar surveys. All right, everyone. Have a great night. Stay tuned for our next webinar. Take care.